right. Good evening, everyone. So it is 8 p.m. and we are going to go ahead and get started with our session today. So thank you everyone for joining in today. And today's session is pretty much a course preview for our SolRx courses. We are going to focus on both OSCE as well as MCQ. So the first half of today's session will be OSCEs, and the second half will shift our focus to MCQ. In today's session, we are planning on discussing what SolRx has to offer and how we can tackle the specific exams when it comes to you writing the PEBCs. We're also going to show you a little bit of showcasing on how we teach for both OSCEs as well as MCQ. And then we will give opportunity to all students to ask any questions and kind of brush up on any concerns that you may have to better improve your understanding on what we have in terms of our offerings. So we're going to go ahead and get started. First off, I want to introduce you to the OSCE team. There's actually many people part of the OSCE team, but we have a select few individuals here tonight, and I'll introduce them. First off, my name is Parmeet, if you don't know who I am. I'm one of the directors here at SolRx, and my main position is one of your main instructors for the OSCE program, as well as the MCQ in terms of management. And I've been with SolRx for many years. My background is I've been a community pharmacy manager for many years with Shoppers Drug Mart. I worked at corporate head office at the pharmacy incident team for a couple of months as well. And I did a couple of years with Sick Kids Hospital in downtown Toronto, where I did a little bit of research on oncology medications, particularly for pediatric populations. Besides that, I've been working with SolRx, and we pretty much do head, as I said before, OSCEs, MCQ, also our pharmacy technician programs, which are the OSCEs as well as MCQ for pharmacy technicians. We also partnered with Canadian Red Cross as well as the University of Toronto to offer our services to them. So with Red Cross, we offer our first aid and CPR courses. And with the University of Toronto, we are one of the precepting sites for students. So students can come to us and learn as they go through their university education. And now I'll hand over the floor to Arav just to do a quick introduction before we move forward.
Thank you, Parmeet. So hello, everyone, and thank you so much for attending the preview today. My name is Arav, and I'm a practicing pharmacist here in Ontario, an independent pharmacy owner and a director at SolRx. And we've been heading and managing the OSCE program and the MCQ program at SolRx for quite a number of years now, and we look forward to having you on board and helping you out in your journey with the PEBC preps. And with today's preview, I just want to encourage all of you to participate, interact with us. That's the chat feature, so please feel free to throw out any questions, and we'd be more than happy to share our experience with you. And as always, which I mentioned, that we eagerly await all of you to practice besides us very soon. So once again, thank you for being here, and I'll hand it back to Parmeet.
Amazing. Thank you, Arav. So there's many other faces that you see on the screen in front of you. Just a quick introduction of them. Vipul is our founder for SolRx. Then we have Heyang, Mohanand, Tumama, Ella, as well as Ala. So all these wonderful people here are our other OSCE instructors, and these instructors are again different from our MCQ instructors, which we will introduce in the latter half of today's session. But these instructors have years of experience with different backgrounds, and they've been teaching OSCEs for many, many years. The one thing that we pride ourselves in at SolRx is that we have many experiences to offer our students. So if you do enroll with our course, you will interact with each and every one of our instructors, including myself, as well as Arav, and we all have something unique to offer, creating the ideal candidate for PEBC. So we're going to start off with the OSCE exam. For some of you, this may be the first time learning about OSCEs. For the others, it may be a repeat attempt, meaning that you've written the exam before, but this time you are interested in possibly taking a course to hopefully get a better result in the next session. But understanding the OSCE exam is essential before you even start practicing for it, because if you don't know what you are practicing for, then it's hard to perform appropriately according to PEBC. So what is the OSCE exam? OSCE means objective, structured, clinical exam. So as the word entails, it's an objective exam, meaning that there is one goal for every single case, and your responsibility is to get to that goal and solve the problem. It is a structured case, meaning that every case should follow a specific structure. And what that structure is, we tell you in our course, and we explain in a lot of detail, and we give you a lot of tips and tricks on how you can build upon your own structure. And then, of course, it is a clinical exam, so it could be in a clinical setting, such as a community pharmacy or even hospital pharmacy. And basically, the OSCE exam is very different than your MCQ and your evaluating exam. It is nothing to do with question and answer. It is a practical exam where you actually have to act out, where your communication, problem-solving skills, clinical judgment, and professionalism are all assessed. The OSCE exam consists of 11 stations. Each station is 7 minutes, and then you have 2 minutes between each station to move. What that means is you finish a station, you have 2 minutes, you go to the next station, and you prepare for it. And you rinse and repeat until all 11 stations are over. This is a mixture of interactive and non-interactive stations. Interactive, there's 9 of them. This means that you will enter the room, you will have an actor there, and you will have an assessor there. Your job is to act out a scenario with the actor and try to solve whatever problem that you find. And then at the same time, you will be assessed within those 7 minutes by the assessor who is sitting inside the room, and they will assess you on communication, performance, and outcome, as well as all the core NAPRA competencies. And then you have 2 stations, which are non-interactive. A non-interactive station, like the name entails, means that when you enter a station, there could be a question and answer sheet, there could be a fill in the bubble sheet, there could be a blister pack that you need to check, or there could be dispensed medications that you have to check. You're essentially going through the case without anyone else in the room, and you are trying to answer whatever questions they are posing. And those are 2 stations in the exam. So again, you have 9 interactive, 2 non-interactive, totaling 11 stations. You also have many rest stations sprinkled in between. And like the name entails, rest means you just sit there quietly and then you wait until the next station begins. And the reason they do that is they try to fit more than 11 stations on one circuit. So for example, if you have 20 students on one circuit, you have your regular 11 stations, and then you will have 9 rest stations. So what do you do during this time? What do you do during the 2 minutes and the 7 minutes? So like I said before each station begins, you have 2 minutes to read what we call a door note. A door note is a piece of paper on the front of the door before you enter the room. It pretty much tells you what to expect in the inside of the room. For example, it could say, patient is waiting for an over-the-counter recommendation. Now, you might think that's a very simple door note, but it gives you a lot of information. You know that there's a patient waiting inside because the actor could be a patient, it could be a caregiver, it could be a doctor, it could be a nurse. But in this case, we know it's a patient. They're waiting inside for an over-the-counter recommendation. When you hear the word over-the-counter, your mind should automatically go to CTMA. So this is a minor ailment case. So now during these 2 minutes, the notepad that is usually provided to you along with the pencil, you're going to use your notepad and you're going to write down notes or acronyms is what we like to use in our course. An acronym pretty much is your structure for that case. And we have specific acronyms for every type of case. So in this example, you would write down your acronyms for your minor ailment case. After these 2 minutes are over, you will hear your starting bell. And the starting bell indicates that your 7 minutes have begun. You will open the door, you'll enter the room, and from there you will see a table, and that table is going to have your references, your patient profile, all the tools you need to answer the case. But you'll notice that the actor will not enter the room for at least 20 seconds. So inside the room will only be you and the assessor. The assessor is not going to really communicate with you. So your job is to see what's on the table and get ready for when the actor enters the room. The actor, who we call an SP, also known as a SA, which is a standardized patient or a standardized actor, they usually enter after 20 seconds. So during these 20 seconds, you want to analyze all the tools you have and be prepared for when they enter. When they enter, you introduce yourself, you get started, and you want to finish the case. At the 5th minute mark, you will hear a 5th minute bell, which is a warning bell telling you that you have 2 minutes remaining in the case. During this time, the actor or patient may ask you a 5th minute question, or sometimes they repeat their opening statement in case it's not already addressed. But at this point, you want to start wrapping up the case, finishing whatever needs to be said before the final bell rings at the 7-minute mark, which means that the case is over. So at this point in time, you would get up and move to the next station, and then your 2 minutes begins again to read the door note for the next station. And then you rinse and you repeat until all stations are over. Now, some students ask me, are these 20 seconds where the actor is not inside the room, are they included in the 7 minutes? The answer is yes. So if you consider this, you technically only have 6 minutes and 40 seconds to complete the station. It seems like it's not a lot of time, but realistically, it is what PEBC expects you to do. Most cases are designed to be finished within 6.5 minutes. So technically you have 30-second leeway to make sure you say anything else that needs to be said. And in our course, we teach you on how you can utilize every single second appropriately and how you can make the most benefit out of every single second. Now, you might be wondering, what do you do at a non-interactive station? At a non-interactive station, you have 7 minutes to finish your question, whatever question they pose, and at the 7-minute mark, you will put your pencil down and you are done the case. At interactive stations, there's a wide variety of types of cases. It could be a patient case where you're counseling a new medication. It could be a doctor case where you are giving a therapeutic recommendation. Or it could be a case where you need to clarify a prescription with the doctor, or the doctor might ask for your opinion, or a patient is bringing in a prescription and you have to identify if there's anything wrong with the prescription. And then what steps you take after that really depends on the outcome expected by PEBC. The assessor, again, just sits there and watches you. And your job is to make sure you really impress the assessor at the end of the day, because that is who is going to determine whether you pass or fail the station. In non-interactive stations, it could be a written response. So you have a question and answer case, a reference will be provided, and you have to go through the reference and answer some questions. It could be dispense checking. So you have a bunch of prescriptions that are already dispensed. You have the prescription copy, and then you have the labels. Your job is to compare to make sure that there are no errors in the dispensed medication. Or it could be prescription screening. You have a series of 5 to 10 prescriptions, and you have to go through them within 7 minutes, along with the references, to see if there's any discrepancies with the prescriptions. And that is pretty much what you can expect when it comes to interactive and non-interactive stations. And in our course, we teach you how to tackle every single type of case, including interactive and non-interactive, using a timed setting. So we have bell systems in place, whether you are online or in person. Now, there are many mistakes students make when it comes to preparing for the OSCE exam. And from our experience, we've kind of noted down the most common mistakes. If I am going too fast, please feel free to just ask your questions on the Zoom chat, and we'll make sure to pause a little bit if needed and answer any questions. Arv is also there to address any questions that you may have, but please don't be shy. But yes, coming back to the common mistakes you want to avoid. So when it comes to mistakes, a lot of students end up memorizing cases instead of learning the structure. PEBC is known for one thing, and that is repetition of cases. They love to bring back old cases because they know that a lot of cases are out there and a lot of students are studying them and memorizing them. But they love to bring it back and they end up changing certain aspects of that case. So if you end up memorizing the outcome, unfortunately, it will lead to failure. Our goal is to make sure that you don't memorize anything. Our goal is to have you develop a structure. That way, any case they throw at you, regardless of it being familiar or not, you understand the flow and you're able to communicate whatever the answer is as expected by PEBC. And I said before, we have many acronyms in this course, and these acronyms are literally your guide to help you succeed any type of case. Other things that students tend to do is ignoring time management. A lot of students, unfortunately, do not practice with a 7-minute timer. So our goal in our course is starting to use timers as early as possible. Maybe in the first 1 or 2 weeks, we are very lenient in terms of time because our goal is for you to understand the case without worrying about the time. But starting right away after week 2 or 3, we start implementing a 7-minute timer, ensuring students are able to finish every single case within the allotted time. So ignoring that, unfortunately, does lead to situations where you're not able to finish the case during the high stress environment of the real exam. Other things students do is underestimate non-interactive practice. Non-interactive cases are meant to be easy. I tell all my students that when you walk into a room and you see a non-interactive case, it should feel like a rest station. You should feel very relaxed and at ease because that's how confident you are with non-interactives. But unfortunately, you will not reach that level if you do not practice non-interactives. So again, you are exposed to over 200 to 300 cases in our course and over 200 non-interactive cases on top of that. So you have a lot of practice, and practicing them regularly really makes you a professional. Fourth point is weak usage of acronyms. Acronyms are out there. Everyone mostly knows what they are. But if you don't utilize it appropriately, then they end up being useless. In PEBC, it is not only about what you are saying, but it's also about what you are not saying. A lot of acronyms have redundancy, meaning that they are there, but they don't need to be utilized in every single case. The best example I can give is lifestyle questions. When you have a patient coming in, you have to ask yourself whether it's appropriate or not to ask them about lifestyle. This can include your exercise, diet, smoking status, alcohol consumption, caffeine consumption. These may be relevant in some cases, but not in all of them. So when some students just follow acronyms blindly, they end up asking unnecessary questions, which eats into their 7-minute timer. So again, it always comes back to time management. And the best way to improve time management is through practice and understanding the acronyms we provide. Then we have role play practice. Our course has dedicated role play every single class, and it is a guarantee that every single student practices more than once in class with the instructor one-on-one. So in some classes, you may practice twice with the instructor, but at the same time, you see all your other peers practice with the instructor. You are exposed to approximately 26 cases per class. And if you look at that, 26 cases over the span of 9 weeks, every single class, you're looking at well over 250 interactive cases, just one-to-one with your instructors. Our class sizes are very small, approximately 10 students, so you really get that one-on-one feedback that you're looking for. And when students don't role play, they only practice with themselves, or they just look in the mirror, or they just record themselves. They end up finishing cases very early, but now when you practice with someone else, you find that you're taking not 7 minutes, but you're spending 10 minutes, 12 minutes doing a case because you did not have that role play practice. And then, of course, delayed studying and practicing. Ideally, you want to study as soon as possible. I know some students have a lot of commitments in their life. You have family, you have jobs, you have work. So it is very hard to allocate that time to study for OSCEs. But OSCEs is pretty much a job that requires time. You want to study on a consistent basis. You want to spend many hours per week. And I will answer that question later on in terms of how many hours exactly. But you want to make sure you don't underestimate this exam. What are the top tips for success? This pretty much accounts for the mistakes. So you want to focus on those and make sure you don't make those mistakes, but you want to focus on structure and not scripts. Like I said before, don't blindly follow scripts or acronyms without really understanding what they're used for. Practice with a timer. We have many recommendations on what timers we use in our course and how to best set up the timer for your own practice. You want to role play regularly, not with the same peers, but with many other people. So with our course, you get access to your batch specific peers, so your 10 classmates, But on top of that, you get access to hundreds of students in our course. So you can always reach out to individuals depending on their time zone, their availability, and set up weekly practices with them to ensure that you're role-playing regularly. And then we, of course, focus a lot of time on understanding and mastering the acronyms in the beginning of the course. So that way, over the 9 weeks, you are utilizing them to the best of your ability. Always making sure that you are given feedback to improve your performance is essential. That is why you have that one-to-one interaction with our instructors. Our instructors not only give you verbal feedback, but they also give you written feedback. And that is something we pride ourselves in. Every single student will have that individualized feedback. It is not a copy and paste. It is literally verbal feedback based on your specific weaknesses. And we work towards that over 9 weeks to ensure you become the perfect candidate before the exam comes around. And again, staying consistent. The way we organized our course, you get before class instructions, you get during class instructions, and you get post-class instructions, all the way up until the mock exam. Even after the mock exam, we give you a guideline, a checklist to kind of follow, a study schedule that you want to utilize before the exam comes around. Now, I do want to give you guys a sample case video of myself performing a case with Haeyang, one of our instructors. And in this video, you can really see how structured we follow our guides, and you are really able to outline the requirements that you would find in a regular OSCE case. But before I show you the video, I'm going to show you an example of a door note. If you remember the beginning of today's session, I told you that you have 2 minutes to read a door note. So what does that door note look like? This is an example. It's quite a lengthy one, but we'll go through it together. Here you see a patient is coming to purchase their regular supply. You have seen him buying the same supplies every couple of weeks. He buys only over the counter from your pharmacy and gets prescription medications from other pharmacies if needed. You have 7 minutes to complete the station, and then you see at the bottom what references you are given when the station begins. So now you have 2 minutes to really understand this door note and get yourself ready with your notepad. To break this down, you know a patient is coming to pick up a regular supply, meaning that is something that they utilize regularly. They usually show up every couple of weeks, and they buy over the counter from your pharmacy only. That means they probably do not have a profile with us because they only buy over the counter products. If you work in pharmacy, you know that over the counter products do not require a profile within the pharmacy. Sometimes we make it just to ensure that we're having the patient's best interest in mind, but most of the times there is no profile. And to solidify that thought, you have your reference list at the bottom. You are given a product monograph, and you know that there's syringes on the table. If there was a patient profile, it would also be listed over here, and it would say patient profile. So now you know that does not exist. So I'm going to show you the video, and then after the video, I will show you our assessment sheet, and I will show you how you are marked and graded depending on how you perform during the case. So now your 7 minutes begin now. Once you enter the station, you will see that right now you have nothing else on the table or in front of you, just the product monograph, which is available and sent to students usually before the classes begin. But in this case, obviously, Haeyang has the monograph with her, and on the table is only the product. I will enter the station after 20 seconds.
So within the first 20 seconds, you will take a look at what you have. You will see what monograph you're given. You will have your door note with you on the table as well. And you will keep an eye on the door to see when the actor comes in.
Hello.
Hi, my name is Haeyang. I'm the pharmacist on duty. How can I help you today?
I want to get 3 ml syringes. I'm going to hurry. Please make it quick.
I can see that you're in a rush, but to help you, I need to ask a few questions to have a clear picture of why you need the syringes. Being a healthcare professional, I like to make sure it's safe and appropriate for you. It won't take long. Is that okay?
Sure.
Please have a seat. This is our private counseling area. Whatever we discuss here will be kept private and confidential.
All right.
First of all, how may I address you? Can I get your full name? if you don't mind?
Yeah, my name is Mike Stone.
Yeah, sure. So, Mike, can I get your age as well?
I'm 30 years old.
I see that we don't have your profile, but before going to the profile creation, I do want to ask, you said you want 3 milliliter syringes. Can you please tell me why you need them?
I use it to inject my medication.
Okay, I see. Do you know the name of the medication you're using?
Yeah, it's a medication called depot testosterone.
Okay. So, Mike, what are you taking the testosterone for? Do you have any medical conditions?
No, I don't have any conditions, but I use it to build muscle. It works wonders.
Okay, I see. This is a hormone that can help build muscles, but it's not really for everyone. Have you ever seen a doctor regarding this?
No, do I have to see a doctor? I just want big muscles. My friend use it, and man, does it look good.
Oh, well, Mike, it is good that you aim to build muscles, but this is not the proper way to do it because it's not healthy. And in the long run, sorry, in the long-term use, it may do you more harm than good. So that's why before using any prescription medication, a doctor needs to assess and make sure it's safe and appropriate for you. Does that make sense, Mike?
I see. I didn't know that.
So do you mind me asking how much and how often do you use testosterone?
I use about 1.25 ml once a week,
And how do you inject it?
into my muscle by myself.
I see. And how long do you have had, how long have you been using this?
About 3 months.
Okay, any health issues from using it? Any symptoms you might be experiencing?
No, I just see that there's a big difference on my muscles now.
Okay, earlier you mentioned that your friends are using it as well. Do you by any chance share needles or your friends by any chance share needles?
I personally don't, but sometimes my friends do it, and I do get tempted when I run low on syringes.
Okay, I'm glad that you haven't shared the needles. And how do you dispose the needles?
I throw them in the trash bin.
Thank you so much for your honesty, Mike. I would like to ask a few other questions regarding your health in general, and would like to create a profile at our pharmacy. Would that be okay?
Yeah, go ahead.
Do you have any allergies?
No,
Do you have any medical condition in general?
I don't.
And apart from this medication, are you using or taking any other prescription medication?
No,
And any over-the-counter medication like Tylenol, Advil, herbal supplements, or vitamins?
no, I don't take any.
And what about any samples from the doctor?
None.
Thank you so much for answering all the questions, Mike. And I would like to ask about lifestyle as well, as this can impact your health and medication you take. Is that okay?
Sure, go ahead.
Do you drink any caffeinated beverages?
Maybe 1 cup of coffee daily.
Okay. And what about alcohol?
1 glass of wine on the weekend.
Okay. And do you smoke by any chance?
I don't.
And what about recreational drugs?
No, nothing.
And do you exercise?
I try my best, but not really, to be honest.
Okay. Mike, so then what about your diet? How would you describe it?
I would say it's pretty healthy.
Okay, that's good to hear that you eat healthy. And thank you for all this information. I just need to check my reference and I'll get back to you shortly.
Sure.
And then I'll take some time to check the reference and coming back, I'll just come back and resume the case. So thank you so much for your patience, Mike. According to my reference, the medication that you're using, testosterone, is indicated for males who have low levels of testosterone, a condition called hypogonadism. And the recommended dose for that is 200 milligram or 2 milliliters every 2 weeks into the muscles by a healthcare professional only, and also with the maximum of 400 milligrams or 4 milliliters per month. Now, in your case, you're using a little more than the maximum dose in a month, and that concerns me because the impact it may have on your health. You're overdosing the medication for a period of time. If that happens, it can cause liver damage, infertility, mental issues such as low mood or hallucination, and in worst case, even stroke and heart attack. And these are just a few things that may happen to you. And I don't want you to go through any of them. And it also carries the risk of dependence. Do you know what dependence might mean, Mike?
No, what do you mean by that?
Well, since you're taking a dose higher than the recommended, when you finally decide to stop, your body might go into withdrawal due to dependence, and you might experience symptoms of irritability, low mood, fatigue, or craving, or even sleep problems, and so much more. And your body creating much less testosterone than it needs. And those symptoms may last for weeks or even months. And this
Nice.
is, yeah, sorry, this is not to scare you, but I would like to be aware as I'm very concerned about you. Do you still want the syringe, Mike?
I want to stop, but what do you advise that I do?
Well, I'll give you a few needles for today for harm reduction purpose. This is not to encourage you to continue this medication, but I'm concerned about you and your friend's health, and I don't want any of you to get any infection from sharing the needles. And I'll give you a sharps container to dispose the needles properly, as storing it away in a regular trash bin increase the risk of having accidental injury to yourself or to others, okay? And more
Okay.
importantly, you must see your doctor as soon as possible to be assessed for your condition, and doctor will guide you in coming off this medication. The earlier we act, the better, okay?
Sure, I can see my doctor later today.
I'm so happy. Mike, now the most effective way to build muscle is to have a healthy and well-balanced diet along with the exercise. So keep yourself active. About 150 minutes of physical activity per week is a good start, and then you can increase gradually from there. It will be also a good idea to speak to a personal trainer and a dietitian to help design a program for you that suits you the best. This will not only help you build muscles, but will also keep you healthy in general compared to using testosterone.
Sure, I can do that.
So, Mike, would you be able to relay my message about using the medication to your friends as well? I'll be more than glad to speak to your friends and help them.
Yes, I'll let them know.
Okay, and is it okay if I give you a call in a day or two to check on what the doctor discussed with you?
That would be great. Thanks for all the information.
Uh,
All right. So that was pretty much the case. Now you might be wondering, how was there any structure, or was there any structure? And if there was an assessor, how are they going to be assessing Young's performance? So that case was technically a complicated case because it was regarding testosterone, which is a controlled medication. There were not many tools available to the student. For example, only thing that was there was the monograph as well as the syringes, but there was no patient profile. So now let's look at the assessment sheet and we'll kind of break it down in terms of what is expected and then how you would be graded for this particular case. And just keep in mind, this is how they grade you for all interactive cases in the PEBC exam. This is the assessment sheet. And here you can see at the top, you're given a mark just for introduction, confirming who the patient is, confirming the reason for their visit, acknowledging them, and then addressing them with their name. And they get 1 point for that. Then you move down. You need to identify, why does the individual need to use testosterone? You don't want to just jump right into information gathering. In real life, when someone comes to you in the pharmacy and they ask you a question, you're not going to start asking them questions about their medication history and their lifestyle, but rather you want to inquire what brought them to ask that particular question. So here is, why do they need the syringes? What's the medication that they're injecting using the syringe? What purpose are they using it? Have they even seen a doctor? How often and how much are they injecting? All of that is very, very important to know, and that is worth 3 marks. Then Young did her information gathering, but she realized since there was no profile there, she asked if it was okay to create a profile. And then she collected medication history as well as lifestyle. From there, you would take a little bit of a pause, utilize your reference, come back after checking the reference, and then explain to the individual why testosterone may not be the best option for them, especially because they're using it recreationally. And then you go ahead and you explain the consequences and what can be done moving forward and how to get off of it. She also made sure to offer a sharps container and offer her help to the individual's friends as well. And that is all considered to be outcome. She wrapped up the case by educating the patient what is the best way to build muscle without the use of any medications, and that is known as your self-care. And then you wrap up with your follow-up. You'll notice at the bottom here that your main areas where you get marked are performance, outcome, and communication. So how do we get these grades? Performance is your total score. So everything is assigned a score. How much did you get out of 15? That determines what your performance is. A level 4 is anywhere between 12 to 15, 3 is 9 to 11, and then so on and so forth. You reduce as your score decreases. Outcome is pretty much the solution of the case. Did the individual solve the main problem? In this case, the main problem was identifying the need of syringes, explaining why testosterone should not be taken, providing harm reduction, and self-care tips. That is all outcomes. So if you notice in our assessment sheet, some areas are shaded in darker than others. If you look at these areas, they're also labeled with OC, which indicates that they are the score particularly related to outcome. And it is out of 10. So if you get 8 to 10, you get a level 4. Anything below, you get a 3, 2, or a 1. And then communication is based on the assessor. Did the individual show empathy? Did they maintain eye contact? Did they have good verbal language? Did they have good non-verbal language? So this is your body language. Are you staring at the patient too long? Are you maintaining appropriate eye contact? Are you shaking a lot on your seat? Are you shaking your legs? All these things are considered when it comes to communication. Those are your 3 main areas. But then on top of that, you get also graded on your competencies. Patient care, did you utilize the patient's name? Did you create a profile? Did you address the concern? You get marked on knowledge and research. How well did you check the reference? Communication, education. Did you sound confident? Was your volume too high, too low? Intra and interprofessional collaboration. Did you explain when to see the doctor? Did you update the profile? Product distribution, and then health promotion. Health promotion is pretty much giving out the sharps containers to prevent individuals from dropping needles in the trash bin. It's also giving out syringes for harm reduction to make sure that if the friends are sharing needles, they stop sharing them. Health promotion essentially means how are you helping other individuals besides the person in front of you? These are all things you have to consider. So now I'm going to open up the floor. Does anyone have any questions about this assessment sheet or anything that I've discussed so far? I know it may seem overwhelming right now, but take it in, ask me any questions that you may have. If not, then we will move forward. All right. One more thing I wanted to point out was this column right over here. I'm surprised no one asked me, but this column right here indicates the time required for every aspect of the case. For example, you should not be spending more than 1.5 minutes asking the individual what they're using the syringes for. You should not be spending more than 1 minute updating the profile. So this is pretty much what we provide students. This is not something that's going to harm your grade by any means if you spend more time in one area or the other, but this helps build time management as best as possible. So Marie, I see your question. Is the assessment sheet uniform to all cases? So the assessment sheet obviously changes with every single case, but the structure of the assessment sheet remains the same for all cases. So there's always going to be communication, outcome, and performance, and they're always going to mark you on the competencies. Every single case in SolRx, all is accompanied by an assessment sheet like this. So you have over 300 to 400 cases in our course, which are accompanied by assessment sheets. And we discuss a lot of other cases as well on top of that. Zahara, it's a prescription med, so he would have seen a doctor. So Zahara, in this case, the patient was using testosterone. It is a prescription medication, but unfortunately, some individuals do obtain prescription medications without speaking to a doctor, which is of course illegal. In this case, the testosterone was being used recreationally, obtained from their friends. So at the end of the day, it is very possible for patients to obtain medications outside of the normal route, which again is not the right thing to do, but it's still our job to educate the patients why they should not be used in this manner. So this case is very important in terms of education and ensuring harm reduction for all the individuals around the patient as well. Another example of a case like this could be patient is coming in and they want to buy an excessive amount of Imodium, which is loperamide. Imodium, if you guys know the pharmacokinetics and the dynamics of it, it essentially is a diarrhea medication, but it is also an opioid, a low potency opioid. So if used in high amounts, it can technically give recreational effects as well. So that is another potential case that you might have to interact with in OSCE case. Any other questions, anyone?
So, Parmeet, if I can just jump in.
Yeah.
I think so, Marie, Zara, these are great questions. And I think so, Zara, what you just pointed out, that is this, if this is a prescription medication, we should be assuming that, the patient should have seen the doctor. And you know what? This is such a great question that opens up so many scenarios that we see in practice, especially for something like this when it comes to diversion of drugs or use of medications inappropriately. Now, as pharmacists, many a times, and especially when it comes to some of these OSCE cases, what they want us to do is, because we are at the forefront, we're easily approachable, patients are coming to us. Firstly, we should try and make sure we never assume. Secondly, we should always not be judgmental. In doing so, as if, for example, if I would assume that, hey, it is testosterone, the patient should have gone to the doctor, what's going on? If you've not gone to the doctor, you know what, rather than giving them, being judgmental that this guy is, using testosterone illegally, I need to report him. Our job as frontline healthcare professionals, or our job as educators, being on the front line, especially when it comes to OSCE cases, should not be judgmental, should be quite educational. We got to put ourselves out there in making sure we appropriately counsel the patient, however that medication was appropriate, and make sure at the end, then we let the patient know that why it is important in that case to see a physician or to see an appropriate prescriber and get it the right way so that further damage doesn't occur, and so on and so forth. So I think so these are great questions. It tells me that you guys are thinking along the right lines. And yeah, and please keep these questions coming. This is how we all learn, and this is how you learn from each other. So I think so there's one more question. Is it wrong to refuse sale of an OTC to a patient if we suspect misuse? So again, this is a fantastic question. No, it is not wrong, because when you refuse, you have to have justification for that refusal. And in giving that justification, that the reason for refusal, for example, if somebody was buying a large number of Tylenol number ones, right, which has codeine, which is available without a prescription with the pharmacist's intervention. If somebody were doing that, if you were refusing it, it's not, you're not doing anything wrong because you're making the patient feel bad and not giving them the medication. You actually are acting in the best interest of the patient, and hence you're refusing it, because too much of it, of Tylenol number one, not only do they get the codeine in it, but at the same time, they have other medications. They have high amounts of caffeine and acetaminophen, which can lead to liver issues when consumed excessively. So our job in that scenario, as an example, would be to refer them to the physician and let them know that there are stronger versions of this medication that are available that can be much more safer, that would be much more better tolerated by your liver, and so on and so forth. So I hope that answers your question, Isaac, I think so. Rebecca's asked, I think so Prameet's taken those answers. Perfect. So guys, any other questions? Yeah, feel free. I think so these are all great questions. And if I can just ask, how many of you attending today are currently working, or can somebody just tell, are you guys working in a pharmacy right now? Do you see some of these scenarios in practice? Have you had cases where people have asked you to buy large amounts of, could be Sudafed, or large amounts of Tylenol number one? Yes, no. So I guess the first question, are you guys working in a pharmacy? If some of you can just type that out, please, that'll be great. I want to just find out if you guys have come across scenarios such as these, and if yes, then how have you seen them being experienced? I have experienced patient taking excessive Gravol. Exactly. There you go. Gravol, we know it's a great drug. It helps with nausea, vomiting, but at the same time can be misused, can be abused in excessive amounts. And how we tackle those scenarios is key. And many times in OSCE, you do get these scenarios because as I said, we want to act in the best interest of the patient by refusing them, but with justification and appropriate education. And we have to direct them to the right course of action, not just say, sorry, I cannot sell you any gravel, bye-bye. No, our job is beyond that, okay? So I hope that gives you some perspective. And thank you guys for shouting out your answers and participating. Parmeet?
Amazing. Thank you, Aru, for that insightful discussion. So we're going to go ahead and continue, and we're going to quickly explain the OSCE course details before we move our focus to MCQ, as I'm sure many of you may be interested in that as well. But in terms of our course, you get tons of tools. And one promise that we make all our students is you do not need anything beyond this course. You don't need additional subscriptions to the CPS, up-to-date, RX files. None of that is needed. All you literally need is the material that we provide you through SolRx, and that will be more than enough to ensure that you pass on the exam. So our course comes with 7 books along with a acronym handbook. Book number 1 focuses on orientation, so it gives you a brief understanding of all the different types of cases. Just speaking about one today, which is the testosterone case we did, that is an educational case, but there's also cases such as counseling. There's also cases with doctors, healthcare professionals, hospital cases, which is a very popular one. And then the holy grail of pharmacy practice, CTMA, there's many CTMA cases you can expect on the exam as well. So book number 1 goes through all the different types of cases and the acronyms associated with each case. And then we have interactive case examples for each type of scenario with accompanying videos of cases being performed by faculty. So you can kind of see how faculty expect you to perform during class. Book number 2 is our non-interactive practice. This is pretty much a summarized version of all CTMA topics that can come up on the exam, including over-the-counter products with their pictures. So if you don't have access to a Canadian pharmacy or you're not able to go in person to look at these products, we have all the products in that book, plus additional practice. This includes the red flag algorithms for the CTMA topics. It also includes the drug tables for all CTMA topics, as well as information on every over-the-counter product available for that particular CTMA topic. Sorry, that was book 3. Book number 2 is non-interactive cases, so it's pretty much the same thing. Non-interactive cases are all your blister pack checking, your dispense management, your Q&A cases, and additional practice. Book number 4 looks at general knowledge. General knowledge could be anything, could be opioid education, could be side effect management, could be information about onset of medications for many medications, because onset is one of those things that are not always found in references. For example, if I ask you the onset of melatonin tablet, many of you would say 30 minutes to an hour, but unfortunately that information is not in the reference. So you really need to have that understanding, and that is what book 4 is there for. If you have melatonin sublingual tablet, it will be a little bit faster than the regular tablet, so maybe 15 to 30 minutes rather than 30 to an hour. That is what book number 4 teaches you. Book number 5 is reference checking, particularly focused on RX vigilance. You do get access to all different types of references in our course. These references include CPS, the CTC, which also includes the CTMA. It includes RX vigilance. It includes RX files. It includes articles, up-to-date articles. It also includes guidelines. But book number 5 focuses particularly on RX vigilance because that is one reference that's becoming very, very popular in PEBC. If you work in Shoppers Drug Mart, then you know it's a very popular reference used by shoppers, but also it is something that we are ensuring students understand for the sake of the exam. Book number 6 is counseling practice. So we have a method called DOSAM, which you're going to learn in our course. DOSAM is essentially an acronym we like to use for counseling. This is dose, onset, side effects, anaphylaxis, and monitoring. Essentially, if you follow this method, you can counsel any medication, including prescription, as well as over-the-counter. Then we have book number 7, which talks about device demonstration. This is a variety of devices. It could be inhalers, pens, patches, sensors. Nowadays, sensors are becoming very popular. the Dexcom and Freestyle Libre sensors are often seen in practice, and we pretty much dispense this on a regular basis. So this is everything you can find in book number 7. And then we have our acronym handbook, which is just a small little tool we give our students so they can always have it on their table or desk printed out so they can always utilize it, especially in the early phases of the class. Zahar is asking, do you get these books as soon as we register? The answer is yes. You get digital copies of all the books as soon as you register. So you have access to them on day 1 and you start practicing them. But we will give you a study guide on how to practice and how to go through these books so it's not too overwhelming. At first, you might think 7 books is quite a lot, but I promise you the way we have developed our study plan, it will be very easily manageable as long as you follow our plan to the T. So in terms of the May 2026 exam, we have many classes available. I'll focus on the on-site classes first. On-site means in person. So these classes are available to individuals who live in the Greater Toronto area or around the GTA. Our address is in Mississauga. It's on 1065 Canadian Place, which is pretty close to the airport. If you know your area from Mississauga, it's about 5 minutes away from Square One, so not too far. And this class is available on Sundays, Fridays, as well as Saturdays. Classes will begin January 25th, and they will happen for 9 weeks. We do have a midterm break after class number 4 to ensure students are able to catch up in case they have fell behind, but this will be once a week, every single week for 9 weeks. And then after the classes are done, you have your mock exams. So this is the schedule for on-site classes. Now, I know some of you may be writing the MCQ in February, so you might be wondering, what about us? We do have an option for you, which I'll explain in a moment. Then we have our online schedule, which is pretty much happening Monday through Saturday, every single day. And we have morning and evening classes. This is all Eastern Standard Time. So 10 a.m. to 4 p.m. is batch 1. And then 6 p.m. to 12 a.m. is batch number 2. You can choose whatever batch works for you, and then you will be registered with that batch again for 9 weeks. And you will do that class once a week, every single week, in the particular batch that you chose. So if you register for Wednesday, batch 2, you will have a class every single Wednesday for 9 weeks from 6 p.m. to 12 a.m. Again, this is Eastern Standard Time, and these classes happen online on our Zoom platform. Some students ask me, is online as beneficial as on-site? I would say they're both equal. On-site is offered for students if they are in the area, but if you're not in the area, whether you're in a different country or a different province, then online classes offer you the exact same experience with the same instructors. So there is no loss in quality in terms of your education. Now, these classes will start in January, end of Jan, but for students who are writing the MCQ exam in February and they do not want to look at OSCEs until the exam is over, we have option 2. Option 2 starts at the end of February, so right after the exams, and this gives students a schedule where they can follow and learn OSCEs without having to worry about the MCQ exam at all. So again, this option is available to those who want to start at the end of February. So for online, we have classes occurring on Thursdays or Tuesdays from 10 a.m. to 4 p.m. You'll notice closer to the end of the course that there will be 2 classes per week. And this is because we want to make sure that you are finishing on time at least a month or so in advance, so you have time to prepare for the mock exams as well as the real exam. And then again, we have another option too, which is going to happen alternating on Saturdays and Wednesdays. So for the first 5 weeks, it will be every Saturday. And then starting from class 6, 7, 8, and 9, it will alternate between Wednesday and Saturday. And then these ones are online. We do have the same option available for on-site as well. On-site will look something like this. It will start on Saturday, February 28th at our physical location, and it will happen once a week, every week, up until you reach class number 5. Then you will alternate between Fridays and Saturdays. So that means 2 classes every week for the last 2 weeks. So Amarachi, I hope that answered your question. Can someone finish the OSCE course from end of Feb to OSCE in May? The answer is yes. We make sure that you finish by mid-April, which gives you about a month and a little over to ensure that you can still prepare and practice for the mock exams as well as the real exam. So it is very possible for you to start at the end of February and be ready for the May exam. This is what our mock exam schedule looks like. So every single enrollment, whether you do online or you do on-site, you get one free mock exam included with your registration. So that mock exam is really your choice. If you want to do it in person or online, it is absolutely your choice. We've had many students take our online course and they live in British Columbia. And during mock exams, they fly in to our physical site to do the mock exam in person. So that is absolutely allowed. Really depends on your schedule and your time. But our mock exams pretty much start in April and they go on for the whole month. And then we will be done by the end of April, which gives us a couple of weeks before the real exam in May. Now, usually the May exam happens near the end of May, but right now PEBC hasn't published the dates. So we can expect it to happen between the 2nd to the 4th week of May. So what makes our course so special? I'm hoping we were able to answer that question throughout the discussion that we had today. But essentially, you get over 250 practical cases. These are interactive cases. You get over 200 brainstorming cases. So these are cases you can do for homework. And of course, these are a mixture of interactive and non-interactive cases. And then you get over 60 non-interactive cases just to practice on your own. It is a small class size, meaning only 10 to 11 students per class, giving you that one-on-one instruction with the instructor. You get assessments every single time in class. So this is an example of an assessment that we did for a student, and that student was performing a case for beta histine counseling in class. You get in-depth analysis for every single case that we perform in class. So even if you're not the one performing the case, you are still watching another student do it, and you are still hearing the feedback the instructor provides. Every single class is recorded, and recordings are given to you within 24 hours. So just in case you need to go back and brush up on a concept that you didn't really understand, or a case that you didn't really understand, you can always go back and listen to the recording. Or if unfortunately you weren't able to make it to class that day, you always have the recording available to make sure you are caught up and you're able to continue practicing for OSCEs. I promised you in the beginning that we give you checklists, we give you guides on what to do on a regular basis. So we do have a weekly progress checker that the instructors will ensure they follow up with you on. So for example, every single week, you are given certain tasks and you are expected to finish these tasks. Of course, sometimes I understand life gets in the way, but our goal is to make sure that you are trying to do your best to follow our planner, and the instructors will always follow up with you in case there's a little bit of confusion, or if it's too much, we can always create a tailored plan for you. So that way it is not too overwhelming. And then finally, something that we really pride ourselves in is our, again, feedback, but this is midterm feedback. So halfway through the course, we give you individualized midterm feedback. So example, you can see on the right-hand side. And this will be given by the instructor to you individually based on how you have been performing for the first half of the class. And the reason we do this is that it allows you to really understand what your weaknesses and strengths are. So that way you can utilize the second half of the class and work on those areas to ensure that you are ready for the mock exams as well as the real exam. And this is something that our course really prides ourselves in, because that allows the student to literally be perfect by the end of the course. We give our suggestions depending on how you're doing in certain areas. After the course is done, you will also be given a schedule on what you need to do before the exam. So what to do 4 weeks before OSCEs, 3 weeks before, 2 weeks before, 1 week before, and of course, what to do a few days before the real exam. The mock exams also allow you to get verbal and written feedback for every single case. So even when you go into the mock, you are getting feedback nonstop by all our trained assessors. And that, again, gives you an idea if you are ready for the exam or not. And we give you enough time between the mock and the real exam. If there are any areas you need to brush up on, we make sure that it is possible. You get unlimited support for our OSCE course. So we have multiple groups available. You have your batch specific group, which is about 10 students. And then you also have your general group, which contains over hundreds of students, which you can interact with your peers and even ask questions to the instructors. And we respond very, very quickly. Usually we tell students that we respond within 24 hours, but you can see from the screenshots here that our instructors generally respond in a couple of minutes, couple of hours. It really depends on the day and the amount of questions that were being asked, but we make sure that no questions are left unheard. So that is something that our course offers, which is unlimited support, which is not something you're going to see anywhere else. Now, before we open up the floor for any questions about OSCE and before we move into MCQ, these are some frequently asked questions I get. So if you have these questions, I'm going to try to answer them. So I understand that there's material floating around everywhere, whether that be our course or our competitors. Yes, there is material out there. Is that enough to pass the exam? Unfortunately, it's not always enough. And that is because PEBC updates their cases every single season. And every single year, references, guidelines are changing depending on Canadian healthcare. And our course also updates all of our material every single season. Not every year, but every single season. So that means we are updating 2 to 3 times a year. Even during courses, we update our material if there's any updates that happen in the guidelines, because it's very important for students to know how to approach the cases. Understanding how to utilize your tools is very important. A lot of students struggle with reference checking. How do you go through a case in 7 minutes and check the reference at the same time? A reference could be anywhere between 15 to 30 pages. How are you supposed to go through all of that and answer the question within 7 minutes? That is something that you learn through our course. Just having the tools is not enough, but knowing how to use the tools is what's very important. So hopefully that answers that question if anyone did have it. Another question I get is 3 months enough to prepare for OSCE? 100%, it is more than enough. And if you register today, you have way more than 3 months. You have almost 4 months to prepare for OSCEs. Usually we recommend 25 to 30 hours a week for OSCEs and about 30 to 35 hours a week for MCQ. And the reason is you do need practice. It is very, very difficult to be successful on any PEBC exam without practicing. So this is our general recommendation, and we really tailor the study guide according to your needs. So if you can only put in 20 to 25 hours a week, it's absolutely fine. We're going to make sure that you are utilizing those 20 to 25 hours very, very appropriately. Never take OSCE lightly. And I answered this question in the beginning of today's session. Do I need any extra material? The answer is no. We give you everything you need. The material that we give you, do you need to print it? You don't need to print the books, and you won't need to print the classes, but ideally you want to print the references that we provide you. So every single class I mentioned, we're doing about 26 cases. So you want to make sure you do print out the references for those cases. And the reason is PEBC so far has only done printed material in all the cases. On their website, they did write down that digital references may be possible, but it's been there for many years and they've never done it yet. But our course still ensures to teach you how to use digital and how to use printed references. Our mock exams will be primarily printed references, but we also offer 1 or 2 cases with the digital reference, just in case. Our goal is always to be a few steps ahead of PEBC. Other times, students ask, can I postpone my course to November 2026 after classes begin? Unfortunately, sometimes students do get overwhelmed, but we try our best to kind of ease that nerve and ensure the student understands that we formulated and structured this course intentionally the way it is, so it's not needed to stress out. But if you ever do ask or consider, can you postpone your course once classes begin, the answer is no. The reason is, Once classes begin, you have a spot reserved for you. Our course is a high demand, so our wait list is quite large. But if you end up postponing your seat, that unfortunately takes a seat away from a student, and they won't be able to enjoy the full course if you leave after the classes begin. Another question is asked, what is the refund policy? Unfortunately, there's no refunds after registration because you receive all content and materials immediately. So, of course, there won't be a refund if you've already obtained the material. So that is one thing you always want to keep in mind. That is why we always urge, if you have questions, call us, email us, talk to us, and we will ensure that you are comfortable before you even register for the course. And that is pretty much what we had for OSCEs today. Now, before we jump into our MCQ course preview, I want to open the floor to any OSCE related questions. And again, I'll give you the opportunity at the end of the session if you have other questions while you think about them. So any questions for OSCEs before we move on? All right. So we're going to go ahead and shift our focus to MCQ then. So some of you may be here because you want to learn about our MCQ course. And our MCQ course has a lot to offer. And again, a lot of different instructors to offer. So first, we're going to introduce two other faces here that you haven't really gotten the pleasure to meet yet. Some of you already may know them, but first off, this is our core MCQ team. So myself and Arav are also part of that team. We particularly specialize in management. Then we have Prague as well as Farah, as well as Hei Young, who is also another OSCE instructor, but she specializes for calculations, particularly in our course. So I'm going to hand the mic over to Prague for his quick introduction.
Thanks, Parmeet. Hi, everyone. My name is Parag Shah. I've been with SolRx for, I would say, over 10 years now. I'm the one of the course developers and management focused instructors. And I introduce myself as a community pharmacist. I think it's very important to understand that pharmacists are frontline professionals and we have so much to offer. And so we have to really understand how to help a patient. And so in our course, that's the essence I like to bring. I'm a U of T graduate. Arav and I actually both graduated at the same time in 2010. I currently am a designated manager. I run an independent practice in a retirement building. So I have lots of experience in community practice, and I'm looking forward to sharing that with you.
All right, so now we're going to move on to Farah.
Hi, everybody. It's nice to meet you. My name is Farah. I'm a lecturer with SolRx. I've been working in PEBC prep for the last 10 years in evaluating MCQ and OSCE. I also work in many different community pharmacies and now own one. So I'm really excited to share my experience and support you all with SolRx.
Thank you, Farah. So we're going to go ahead and get started with Farah's part of the day. So Farah, the floor is now yours.
Thank you so much. So, when it comes to the MCQ exam, you have to keep in mind that it is quite lengthy. It is 4 hours and a half long. There's also post-exam survey. So, when we look at the number of questions, you will realize that you get about a minute and a little bit per question. You may feel nervous thinking, how can I take 1 minute to attempt a question? But here at SolRx, we provide you with all the tips and tricks to look at a question and assess it and answer it very, very efficiently. This exam is a computerized exam. It used to be years ago on paper, and then in the last 10 years, it became a computerized exam. You could either do it remotely or you can do it at an exam center. So, your exam is 200 questions, and what you have to keep in mind is that only 150 out of 200 count towards your score. So, 50 questions don't count, which is kind of crazy to me, right? So that means that a quarter of your exam doesn't count. And a lot of students will say, well, do you know which questions count and which ones don't count? We don't know. The PBC does not tell you. The questions that do not count towards your score are considered to be pre-test questions. And the PBC says that these questions are there for the PBC to see how students score on these questions and evaluate if they will use them in the future as part of the exams. So of course, we never will know what they are. However, with a lot of experience and over many years, we can say that any questions that seem kind of out there beyond the scope of a community pharmacist or treatments that are not commonly used in practice may be considered pre-test, but that is also something interesting to keep in mind. And we train you to try your best to identify them on your exam. When it comes to the qualifying MCQ exam, it is different from the evaluating exam. So on your evaluating exam, you need a passing score of 60%. No questions asked, just 60% of to get on your exam. MCQ doesn't really work that way. So what the PBC does is they look at different competencies from NAPRA. So NAPRA is the National Association of Pharmacy Regulatory Authorities. And they have these different competencies that assess an appropriate pharmacist's ability to practice. So they look at ethical areas, patient care, management, knowledge, and many different areas. And they weigh these areas differently on the exam. And what happens is each question can test on different competencies, and they will look at how every student does on a question. So let's say there was one question that was super, super hard, and majority of people did it very poorly or scored poorly on it. Then it is very likely that that question will be weighted less. So I always encourage students to, when they are starting their exam, look for questions that they are confident in, and then warm up and then attempt the questions they find very difficult. I still remember when I went into my exam, I froze. And every question I looked at, I blanked out and I didn't know what to do. And I didn't know anything. I said, I don't know any of this. I don't know what this is. And then I went further and further towards the end. I found a question I knew, and then I worked my way backwards. And then I found that I was able to warm up and mold my brain to attempt the harder questions. So how does the PBC grade these exams? The key thing that you have to understand is it's not like evaluating exam, like we mentioned. It's not like a 60% and then you pass or fail. They look at how everybody does on each question. So that's super, super important. And every exam is different. So they have a specific randomization where every student will have a different version of the exam. Some students will have maybe more cardiology. Some students will have more psychiatry. So everybody will get a different set of questions. And we have also written different ways and different things that the PBC incorporates when they look at how a student passes. But the key things that I have just mentioned are the most important when writing your exam. Are there any questions regarding how the exam is scored? I know a lot of students get confused with evaluating versus MCQ, or any questions. You guys are super quiet. I know it's Friday night. Any questions?
Yes.
Yeah.
Hi. Good evening.
Hi.
Okay. I was just wondering, are there like topics that weigh more than others? Let's say cardiology, endocrinology. I was just wondering.
Yeah, and that is such a good question. And I remember like 10 years ago when we first started out teaching, I would be able to confidently say, cardiology is more common than HIV, and cardiology is most commonly tested. But what we found is since COVID, a lot has changed. Now, there isn't a priority given to a topic. So you can be tested on every topic. So it's very, very important to divide your attention among all the topics. However, with experience, we will find that certain topics are not tested as frequently, but we do encourage that you divide your attention to all the topics. Even if you see cardiology more than certain psychiatry topics, you must divide your attention and we will guide you. However, some students will say, oh, Farah, you spent this many hours teaching cardiology versus this many hours teaching, I don't know, dermatology. And that could be because cardiology has more topics, so we naturally give it more attention. However, when you look at individual topics, you must do everything equally. If Dr. Parmeet would have any feedback to add in regarding that question as well, that would be appreciated.
Yeah, so I actually agree with you, Farah. I remember during my exam, a lot of my questions were focused on diaper dermatitis. And you might be wondering, what is diaper dermatitis? It's just a small topic. But for me that day, a lot of questions were based off that. Other colleagues had a lot of psych questions, a lot of cardio questions. So it is very random, very up in the air. Now, Marie's asking a very good question as well. How does PBC compare how students fared on a particular question if all the exams are different? So there are many, many questions out there. And nowadays, I think very recently, PBC has changed a little bit where they claim that every single exam has different questions. But again, obviously, there might be some repetition, and there's a lot of pre-test questions, as Farah mentioned, Mary. So that is pretty much what they're analyzing. There's a lot of ways PBC looks at it. Unfortunately, they are not very public with the way they do it. This is just based off our experience and looking at students' reports on when they fail the exam, unfortunately. So when a student does fail, PBC sends out a report 6 weeks after, and their report is always focused on competencies, which Farah mentioned quite heavily. That tells us that they do score the competencies depending on their weight. But at the same time, we also have to consider that there's a lot of pre-test questions out there, which I'm assuming are repeated with certain students. So it's hard to answer that question, Marie, but I'm hoping that kind of answers it.
Sorry if I can jump in. So Marie, I think so just to build upon what Parmeet was saying, is in that feedback report that you get, it's based on competency. So what happens is when two people get an exam and if the questions are different, their competency for that question might be the same. So let's say if Parmeet and I are attempting this exam, both of us, if we have different MCQ questions, yet we might have questions from health promotion, for example. So my health promotion and the cohort's health promotion performance is then compared. And if you note in the feedback report, they are basically comparing your performance in that competency with the cohort's performance in that competency. So yes, the questions might differ, but the relative performance per competency is what is assessed. So I hope that gives you and sheds some light on how they would assess or put all of you on the same level field, even though the questions are different, because the competency will remain the same.
All right.
Is there a reason PBC released the results 6 weeks after, since the exam is digital? Any known reason why it takes time? So yeah, I think so. Parmeet's answered that, and no, I think so. The reason is that's just how they do it. I mean, unfortunately with PBC, sometimes they have a mind of their own, and that's their policy. My assumption would be that they want to give some time for people to just, I guess, relax after the exam. But I think so. More importantly, it's for them to get all of their act together and make sure that, as I just said, the comparison of the cohort, the comparison of the competencies, all of them falls appropriately, and then they probably want to put the results out. Again, that's an assumption I have, and that's probably why they take the 6 weeks.
Thank you so much. So moving on to the next very important question. Is it enough to work through a question bank or practice past questions, or do you need formal training? So you have to keep in mind first that the questions do evolve, they do change. Some questions may be repeated, but the questions on the MCQ exam are not straightforward. So what I always will tell students when it comes to the clinical areas, don't look for an option on your exam. When you're evaluating a question and you have 4 options, don't look for the option that is right. Avoid thinking this is right versus this is wrong. You have to look at what is most appropriate based on the information you are given. A lot of times you will go into a case and you'll read it in your mind, you'll say, oh, this drug is first-line therapy. This drug would be the most appropriate. And then you will look at all four options and you'll say, why isn't that there? And the PBC makes the exam that way, where you're not looking for right or wrong, you're looking for the most appropriate answer based on what you are given. So we mold you to think like that, where you're looking at patient side effects to pick a drug therapy. You're looking at patient preferences, because ultimately patient preferences come first. Even if you pick the best drug out there, which is the most evidence-based, the number one treatment option, if the patient doesn't go home and take it, or if they throw it out, then you don't pass that question, right? So that's something to keep in mind. So we provide you with all the tools and the skills to attempt these difficult questions, and we help you put your critical thinking hats, because these questions are not black and white. They require a lot of analysis and experience, which we will provide you as practicing pharmacists. Okay. So exactly, and this is just written to reiterate what we are saying. So it's beyond memorization, way more. Again, I still remember every semester a student will tell me, how come first-line treatments were not directly tested? We had to look at patient preferences and allergies and this and this. That's how they make this exam. And even when you look at contraindications, when we look at the word contraindications, in our mind, that means that a drug cannot be used for a patient, but there are different types of contraindications. There's relative, there's absolute contraindications. How do you differentiate between them? How do you apply that in the clinical and non-clinical situation? So we provide you with all of those tools, and these tools are not written. They can only be taught with experience. Okay? So we provide you with everything you need to succeed. This is just a snippet of some of our materials. Our materials are based off of the CPS, Canadian Pharmacists Association, and evidence as well. So we provide you with all the tools you need in one place. You do not need to go to any external sources. Okay? And we answered this question, as one of our dear students asked already. Are there really any high priority questions? Remember to study everything equally, and we will guide you. And if you're not sure, hey, I don't know how much attention to give to a topic, we will provide that information for you. We'll hold your hand and help you through it. So before we get started, I'm super excited to touch on anxiety disorders, just to give you a bit of a taste of a clinical topic. Do you guys have any questions? Anything at all? Any doubts so far? MCQ can be overwhelming, and there's so many, different groups and different things people talk about, right? So it can be overwhelming. Anything at all? We'll just wait a couple seconds. Okay. So are you guys ready for us to get started with anxiety disorders? Okay, so when it comes to anxiety disorders, it is a group of different disorders, but in the past, they used to be obsessive compulsive disorder included and post-traumatic stress disorder included as part of anxiety disorders. And then something called the Diagnostic and Statistical Manual 5, which is, I guess you can say, the ultimate source of diagnosis of psychiatric disorders. That source separated them. You do not need to know how to diagnose psychiatric conditions on your exam, but it is important to know how it is diagnosed, in the sense that psychiatric disorders are diagnosed through the DSM-5, which is the Diagnostic and Statistical Manual 5. That is a bit of a tongue twister. Okay, so there are different types of anxiety disorders, which we have listed below: separation anxiety, selective mutism, specific phobia, social anxiety, panic, agoraphobia, general anxiety, and anxiety due to another medical condition. Okay, When you are trying to pick between understanding and memorizing the different types of anxiety disorders, the first thing I always ask myself is it drug induced? Is it not drug induced? Did something change in a patient's life? I've seen patients have panic attacks and go to emerge. They thought they're having a heart attack. They're feeling very, very jittery and chest tightness. And they'll do a whole bunch of tests, and they will then believe that the patient actually was having a panic attack or has an underlying anxiety disorder that was not diagnosed. Even abnormal thyroid levels can also cause anxiety-like symptoms. B12 deficiencies and other conditions can mimic anxiety disorders. And of course, today we're not going to go into every single detail, just very, very high level for you to get a bit of taste of our clinical content. And then generalized anxiety disorder is one of the most common types where a patient is anxious about so many different things in their life. So they'll worry about, for example, maybe waking up, worried about what to eat for breakfast, worried about being late to work, worried about the weather outside, and worried about so many different things. But ultimately, when it comes to any psychiatric condition, the biggest question we ask ourselves is the patient's ability to function compromised? If they can't go to work, if their ability to do their regular activity is compromised, then and only then is it considered a disorder. So what are the goals of therapy? For every single topic we will highlight in the class, you must understand the goals of therapy. Is it a condition we can cure, or is it something that we can kind of put under control? Does the patient have to take the medication for the rest of their life, or is it temporary? So you have to understand, and you have to set the patient up for success. It's kind of like, when you give a patient Tylenol or acetaminophen, if they take it within an hour, they should feel relief. But if a patient takes an antidepressant for an anxiety disorder, are they going to feel relief within an hour? Probably not. But if you don't tell them that, how would they know? So it's all about setting the appropriate expectations, and we will guide you through that in the course. When it comes to the role of pharmacists, because we're the most accessible healthcare providers, we have more regular interactions with patients than maybe their primary care provider, nurse practitioner, or physician. So we can see how a patient's condition is either under control or deteriorates. We cannot diagnose anxiety disorders. We're not family physicians or psychiatrists, but we may be able to get a sense if something is going on. So we can screen the patient. We can ask them, hey, John, in the last 2 weeks, have you suddenly been feeling panicked or scared or more anxious than usual? Are you feeling more on edge than usual? Is anything going on? And if you believe something is going on, you can say, you know what? We think it's time you go see your primary care provider, and you can guide the patient to their resources in the community. When it comes to non-drug measures, there are many different non-drug measures for anxiety disorders. And for mild to moderate anxiety disorders, non-drug measures can be as effective as drug measures. The downside of non-drug measures is they're not typically covered. They can be expensive. They may not be covered by insurance plans, but also they require a lot of work. You may have to go for weekly therapy. You may be provided with homework. And so you have to be very, very, very consistent with non-drug measures. Of course, we are not therapists, and we cannot go into significant details of non-drug measures, but we can say to a patient to look into the community for non-drug resources. When it comes to the treatment algorithm, one of the biggest things I remind the patient is how long they should do a trial of the medication for. And I have seen this appear on the exam. When somebody starts an antidepressant, when they initiate the therapy, how long does it take to take effect? And does it take effect within a week? when it comes to depression versus anxiety, which one shows an benefit more quickly when a patient takes an antidepressant? So for example, if a patient starts an SSRI for depression, they may see significant early improvement in the first 2 weeks. And this early improvement allows us to see how they will do in the next 6 months. Versus with anxiety disorders, the benefit takes a lot longer to kick in. So for anxiety disorders, it takes at least 6 to 8 weeks to show relief. Versus in depression, as early as 2 weeks, you will see some kind of benefit. So you have to know these timelines. You have to know, okay, well, when a patient is at a therapeutic dose and they're feeling better, how long do they continue therapy for? For an anxiety disorder, they continue therapy for 1 to 2 years, versus in depression, we continue for about 9 months at the therapeutic dose. But if they have a history of suicidal thoughts, of family history, we may even continue therapy for up to 2 years. So in the course, we will compare and contrast the different types of disorders, as you have to know the exact timeline, since they can ask this on your exam. When it comes to picking drug therapy, how do you pick? So different types of anxiety disorders will have different antidepressants that have more evidence. So for example, panic disorder with or without agoraphobia, what does that mean? Agoraphobia means that a patient is afraid of not being able to escape their surrounding. They may not want to be in an airplane, for example, because if they go into a plane, they feel enclosed and they can't escape, or if they will avoid crowds because they're afraid of not being able to escape. So some people will get panic disorders with agoraphobia or without agoraphobia. So you will see in this condition, you will see that citalopram has evidence, but citalopram does not have evidence in social anxiety disorder. In social anxiety disorders, it is considered second line, not first line. And then in generalized anxiety disorder, it is not first line nor second line. In the course, we'll provide you with acronyms to help you memorize which drugs are used for which conditions. Like my favorite one is for generalized anxiety disorders, I tell patients, elephants parade swiftly, very delicately. Elephants parade very swiftly. No, elephants parade swiftly, very delicately. So escitalopram, paroxetine, sertraline, venlafaxine, duloxetine. So if you remember that, you will remember, oh, these are the drugs for generalized anxiety disorder, but we'll go into that when we get to the class. Special populations are very important for every clinical topic. A lot of students will say to me, well, Farah, why is sertraline or escitalopram safe in this psychiatric condition and not in this other condition? When they are looking at treatments for special populations, it's not really ethical to give a whole bunch of medications to patients who are pregnant and see what happens, right? So what they'll do is they'll say, oh, a whole bunch of pregnant females used escitalopram and the mom was okay, baby was okay, so it is likely safe. So even when you look at the terminology in the evidence, they'll say it is considered safe. It's never like it's 100%, because it's never 100%. We look at what has been used, and that's where the recommendations come from. When it comes to psychiatric conditions and in pregnancy and breastfeeding, I tell students, when in doubt, go to sertraline, because sertraline in 9 out of 10 situations is safe in both pregnancy or breastfeeding, versus paroxetine we do not use in pregnancy. But paroxetine can be used in breastfeeding. But are we really going to start somebody on paroxetine right when they're starting to breastfeed? No, you'd want them to be on the same medication during pregnancy and breastfeeding. That's why sertraline tends to be a very good option. Children and adolescents now are being diagnosed more and more and more, and there's a growing body of evidence supporting treatments for this population. If you look at the drug monographs, which you don't have to, we do that for you, but there are warnings in there, or patients will read online that, oh, in those who are under 18 years of age, don't use antidepressants. Okay. Generally, we recommend non-drug measures. However, drug therapy is effective. And some sources will say, well, antidepressants increase the risk of suicidal thoughts in youth. However, you have to keep in mind that the psychiatric condition itself can increase the risk of suicidal thoughts. So we don't necessarily know, we can't conclude 100%, is it the condition or is it the drug itself? And at the end of the day, we have to support the patient. And so now we're seeing many more youth use antidepressants, and they are succeeding in treatment. So why don't we do just three questions together? So let's take a moment to look at our patient RR. So RR comes to the community pharmacy with their daughter, and they're looking to get some pharmacologic management options for a newly diagnosed anxiety disorder. Our patient, RD, is a 22-year-old woman, no medical history, no substance use, or any seizure disorders. Okay, so our patient has panic disorder without agoraphobia. Patient has unexpected panic attacks, shortness of breath, and they are affecting the patient's ability to function. So that gives us a clue, right, that there is a disorder going on. And so they want to know and they want to understand which treatment options are supported by the evidence. So what do you guys think? I know we didn't go into it, but why don't we give it a shot today? Which treatment do you think would be the most appropriate for our patient? We're looking specifically at panic disorder. So why don't we go back just for a quick second to our table, look at the drugs for panic disorder. Perfect. So when we're looking at panic disorder, the SNRI indicated is venlafaxine, and the SSRI is citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. So if we scroll forward to our question, what do you guys think? Any ideas? And that's okay if we don't know. I'm happy to discuss the answer. The answer here would be A, because the question is asking what is the most appropriate information we can give, and it's A. So I said earlier or just now that venlafaxine is the only SNRI indicated. So A would be correct here, stating that duloxetine does not have enough evidence, which is true because it doesn't have enough to support its use in panic disorder. So A would be the answer here. And of course, we'll go into more details in the course. On to the next question. So during the same consultation, RD raises additional concern regarding future family planning. She's not pregnant. She anticipates that she may be pregnant in the future, and she wants to start a medication that is safe. Okay, so what do you think, which medication would be safe for our dear patient? I know that I already said pick sertraline when in doubt, but sertraline has not been listed here. I did mention that we cannot use paroxetine, so that'll rule out C. And we had in our slide that escitalopram is a suitable option. So in this case, B would be the answer. So we would go for escitalopram because it does have sufficient evidence to be considered safe in pregnancy. Okay. And then finally, RD comes back to the pharmacy. They want more clarifications. How long does it take to have benefit? When can they reasonably expect improvement, to see improvement in their panic attacks? So when a patient is at a therapeutic dose, when should they notice benefit? Okay, so we set in the slide briefly that within 6 to 8 weeks, at a reasonable dose, they should see benefit. Within 6 to 8 weeks. So in that case, the answer would be D. And of course, we'll go through it in more detail in the course. I know it's late on a Friday night. Does anybody have any questions before we continue with our colleagues to calculations and management? Any concerns regarding the therapeutic topics, therapeutic concepts? I know it can be overwhelming and a lot of materials. No? Alrighty, well, we really appreciate it and we'll pass it on to Dr. Parag. Thank you.
Thanks, Farah. Okay, so you guys got a kind of a taste of how we do therapeutics. So now we're going to go on to the two other major parts of the exam. So if you want to look at the exam into three parts, we have patient care therapeutics, then we have calculations and management. So here's a question that I want to pose to you. How should students prepare for calculations and management? As you can imagine or experienced, they are prepared very differently. They are quite different than patient care. Patient care and therapeutics can be thought of more guideline driven, more algorithm based, or clinical knowledge focused, right? It's heavier on knowledge recall and application. Now let's talk a little bit about calculations. So if we can, before we get to that, pardon me. So calculations, yeah, great. So just to kind of give you a preamble here, calculations, it can be a big bane of everyone's existence, in a sense, a weak point. We must know the formulas, but we have to go beyond just the formulas. We have to know how and when to apply these formulas. As we know, the questions are often practice-based. It's not just pure math, right? We're not in school where it's just kind of algebra or just very simple numbers together. They give a scenario, and that is what is expected of us as pharmacists. It requires an understanding of the scenario before doing any calculation. You can't just go right into the numbers. You're going to get it wrong otherwise, right? Again, I mentioned it reflects real-life pharmacy scenarios. The great news is that, as mentioned earlier, we have dedicated classes for calculations. So what that means is all we do is calculations for those multiple classes. And we're glad to say that we have a dedicated calculations expert instructor with Hayan. Okay. And another nice thing that we've been doing now is with regular engagement with our group chat, we actually pose calculation questions for candidates to get an idea and practice and discuss. So that's calculations. Now, management. Management is a beast, but is a beast that we can tame. Management is about judgment. It's about prioritization. It's about decision making. Okay, it cannot be memorized. Unfortunately, it is more complicated than that. It requires deep understanding of management concepts. We're dealing with people. People are not perfect. People can be messy, but we have to help the patient and we can figure it out if we have a structured approach. And that's what we're teaching you. Okay. So as you can see here, there's a number there, 58%. 58% of the exam is not about medications. Okay. If you base it on the PEBC blueprint, which is, you can look at it. I hope you have. 42% is based on clinical knowledge. 58 is everything non-clinical or non-patient care, which includes management, ethics, operations, safety, health promotion, evidence-based practice and research, drug distribution, etc. Now, the unfortunate thing is that some candidates overstudy therapeutics. I just told you that the majority of the exam is non-drug based. Of course, when we look at the exam or real life practice, we of course have medications and drug therapy that are involved in the management cases or ethical cases. The point here is that these questions are important. They, represent a big chunk of the exam, And unfortunately, they can feel at times vague, uncomfortable, and hard to self-study. These questions can determine whether we pass or fail, okay? So ignoring this section is a major risk. The good news is that you don't have to do this. You can fully complete these questions properly with guidance, teaching, and instruction. Next. So, non-patient care does not mean unimportant, right? It reflects real-world pharmacist practice. It includes pharmacy management, workflow, interprofessional collaboration, medication safety. These questions are situational. What does that mean? That means that every scenario can be a little different, a slight twist. So we have to look at each situation and quickly dissect the key pieces of information and utilize the information provided to get the best answer. It's a gray area, right? That's the problem. It's not black and white, but we can help you navigate this gray area. It's judgment-based. This is especially challenging for candidates without Canadian experience and is often misunderstood and underestimated. But we have some good news. Pardon me, next. SolRx, I would like to say, are the experts in this gray area. We were amongst the first to specialize in management, okay? I want to stress something right away. We are all practicing frontline pharmacists. We do this day in, day out. So when we say that we experience this, that is the case. Even today, I went through some of the cases that we talked about already in this course preview, okay? The focus is not memorization. It's a structured decision-making process. So we teach you how to analyze these gray area questions, how to eliminate almost correct options, right? That's the devil in these questions. They will give you multiple correct answers, but we have to pick the most appropriate, most applicable answer. We have a proven approach for international graduates. Okay, let's not leave this 58% to uncertainty. That will equal high risk. Now, a new thing that we've done in this cycle that we're really excited about is we are actually creating a dedicated module called Foundations of Canadian Pharmacy Practice. So this module includes short videos and guided notes that cover the basic fundamental professional responsibilities, legislation, and practice expectations in Canada. What does all that mean? So we've created a module that is specifically designed for candidates who are new to the Canadian pharmacy profession or have little to no experience working in a Canadian pharmacy. So everyone starts the course with the same strong foundation and context. Okay, so I'm going to pass this on now to Arav, who's going to go through some cases with you.
Perfect. Thank you, Parag. So I think so we touched upon a little bit of therapeutics with Dr. Farah, and Parag gave you a great sense and an idea of how we approach the management section. So to put it into practice, let's try and demonstrate how we discuss case-based questions in our course. So as I had mentioned earlier, and we always do that in our course, I would like to urge that please read through the case, and then there'll be 2 follow-up questions on it. And I urge all of you to please participate. Again, we learn from each other. So at this point, give it your best shot and put a right answer. Even if you get it wrong, that's not a problem. We're learning. Let's read the case together, and then I'm going to highlight the competencies that we are touching upon in this case. All right. So you are a clinical pharmacist overseeing medication inventory management in a tertiary care hospital pharmacy. Now, obviously, we'll talk about primary, secondary, and tertiary care in our course, but hopefully at this point, a lot of you may have an idea. It depends on your point of contact of how you got into that setting. That's what the levels of care talk about, but we'll go into details during the course. Now, during a routine narcotic audit, you identify a discrepancy in the perpetual inventory of hydromorphone 2 milligrams per ml ampules. Does anyone over here, by any chance, know what perpetual inventory means? Perpetual inventory, guys. If you can just type out some answers while I continue reading the case. the records show that 100 ampules were dispensed from the automated dispensing cabinet, the ADC, but only 90 were accounted for. Obviously, this is telling us there's a discrepancy. A review of electronic health records, EHR, and narcotic access logs reveals that a newly hired nurse retrieved the missing ampules but did not document administration or wastage. At the same time, a medication storage inspection reveals that multiple vials of potassium chloride injection are stored in an unlocked medication cart in a high-traffic area. You are responsible for ensuring compliance with ISMP Canada, narcotic control regulations under the CDSA, and hospital policies. So we're going to take a few of these points into account. Before actually we point that question out, Parmeet, if we can just, yeah. So one thing I want to highlight, when you're approached with a case like this, obviously everybody approaches cases differently. Everybody's way of reading, speed of reading is different. But the way I like to do it and emphasize is I try and highlight some important points. Now, as somebody, I guess, Chi mentioned out, this is great. Perpetual inventory means continuous inventory. The inventory is managed in real time, as opposed to periodic inventory, which means we rely only on manual counts of the tablets done periodically, every 3 months, every 4 months. Obviously, the periodic manual counts are much less expensive, whereas perpetual inventory maintenance is higher because of the reliance on technologies such as the pharmacy software. So that's what I guess perpetual inventory would be in this case. And thank you guys for pointing that out. So the way I would approach this case is I would highlight important points that this pharmacy or this hospital pharmacy does perpetual inventory. So they're regularly keeping an eye and counting their inventory, which is a great way to do it. And hence, they ended up catching an issue in their narcotics. There is a discrepancy. So that's the first part of the question. The second part of the question talks about potassium chloride and how we all know potassium chloride is a dangerous drug. And if not accounted for properly, if used or if misused, it can be fatal. So this question actually is targeting two competencies as far as the exam point of view. One is it looks at product distribution because we're talking about inventory management through narcotic reconciliation. And we're also going to be focusing on medication error prevention. Hence, we're going to be talking about quality and safety. And obviously, it does touch upon a little bit of narcotic control regulations, which is federal legislations, which I highly always urge you guys to know because that is one area that is not as much gray as other management topics. Federal legislation is black and white. You need to know the legislation. You need to memorize parts of it. And those are easy points for you in the exam. And those are questions you should absolutely right away off the bat be able to answer fast. It'll help you with your time management as well. Okay, so moving on, hope everybody's understood the case and has points of the case noted down. Let's look at the first question. What is the most appropriate immediate action regarding the hydromorphone inventory discrepancy? Read the question carefully. Immediate action. Conduct, option A, conduct a full narcotic reconciliation, contact the nurse for clarification and escalate the issue if documentation discrepancies persist. B, file an immediate report to Health Canada and notify the police as narcotic diversion is suspected and it can turn into a much bigger problem. Adjust the inventory to reflect the missing ampules and continue monitoring future transactions for any more discrepancies. And lastly, lock out the nurse from accessing all narcotics in the ADC, which is the automated dispensing cabinet, until an internal review is completed. Ilvan, yes, these will be shared. If you've given your email address, then the recording of this preview will be shared with all the candidates who attended. And I'm sorry, we're sorry that you have to go, but absolutely, we're glad that you were here up until now. All right, so we have a few answers. Answers A, anybody else? File an immediate, lock out the nurse. I mean, yeah, it is a newly nurse. Everything is pointing in the question in the case that the nurse was, it seems like certainly that the nurse is responsible, but there is an important piece of information giving that it's a nurse that has just recently started their job. Do we jump to a conclusion? Do we not? Right? So we have some A's, some D's, and this is what management is all about, right? This is where we usually end up with two options that are the closest. which are fighting for space to be marked as correct on the answer sheet. And that's what's happening. Anybody else before we move on? Okay. Great. So this is great. I'm really glad to see that all of you are participating. And, you know, it's thought-provoking. So let's look at which is the answer and why. So for all those that pointed out, A, yes, A is the correct answer. The reason in this case that A is the correct answer is a full narcotic reconciliation and clarification with the nurse is essential before we jump to any conclusion. If the discrepancy remains unresolved, that is key. If after doing that initial reconciliation, even though we are doing a perpetual in this case, inventory, in spite of that, if there is a discrepancy after doing that reconciliation, if it is unresolved, absolutely escalation to Health Canada, Office of Controlled Substances, escalation to management and security is going to be required. Now, yes, theft is a concern, as we see in B. But again, as mentioned, we don't want to immediately jump to conclusions without doing an initial reconciliation. Now, adjusting inventory without investigation is absolutely a no-no. It's non-compliant, and that should never have been an option. It should be crossing your mind, because that means you're trying to cover up the tracks and you're going to close the books and move on. And actually, that error is going to get bigger and bigger and bigger. So never, ever do we cover up an error. Never, ever do we blame an individual. In general, I'm talking, okay? And just keep in mind that you never want to do something which is going to lead you into trouble with the college, or it's going to act as if it basically makes them think this is professional misconduct because you've covered your tracks and you've just moved on, okay? So that should never be the option you should be picking. Now, the locking out of the nurse is also, in this case, not an option because due process needs to be followed. Because there could be HR policies. We need to investigate further that is it just because the nurse was new and did not know the policies and made an error and they forgot to document something, and that's why we led to this issue. So that's why it's important to do that initial reconciliation, and hence option A is the correct answer in this case. I hope that makes sense, everyone. Any questions? No, Chi. Reconciliation, adjusting inventory is not the same. Reconciliation means you are reconciling the physical count, the manual count that you're actually physically coming up with when you count the tablets with the perpetual inventory in your pharmacy software. So the automated inventory that is being maintained when a tablet is being dispensed, it automatically gets deducted, and your pharmacy software ends up with a real-time inventory. That inventory is basically trying to be matched up with a physical count. That is what is called a reconciliation. You're trying to reconcile the two different counts, the perpetual counts and the manual counts. That is what reconciliation means. Adjusting inventory is not, it's completely different. Adjusting inventory is once you have an answer, once you know that why there was a discrepancy, it could be a waste, it could be a forgotten documentation of destruction. That is when you would go ahead and adjust inventory after following proper protocol and after having answers as to why there is a discrepancy between the perpetual or the automated inventory count and the manual count. Does that help? Does that help you answer the question, Isaac? I hope that sheds some light that these are two different concepts. Okay, perfect. Yeah. So let's move on. Let's look at the second part of this question. What is the most appropriate response regarding the storage of potassium chloride? So as mentioned, the first question was to do with product distribution because we talked about narcotic reconciliation and protocols. The second question now we are moving on, and we're talking about quality and safety, another competency that is heavily tested upon in the exam. So what is the most appropriate response regarding the storage of potassium chloride injection? As we all know, potassium chloride, if used inappropriately, it's highly fatal. But intravenously, KCl is used sometimes commonly to help with electrolyte imbalances. It's used for sometimes moderate to severe hypokalemia and some other indications as well. Let's look at the four options. Relocate all KCl vials to the automated dispensing cabinet or a locked area to prevent accidental administration. Ensure the vials remain accessible for emergency use, but label them with high alert warning sticker. Train nurses to double check the KCl before administration instead of moving storage locations. or leave the vials in the unlocked cart, as potassium chloride is not classified as a narcotic. So 4 options. I hope, do you guys want us to go back to the case, or everybody knows what the question is asking? Anybody want us to go back to the case, or? Okay, so guys, what we're trying to do, what the case is asking you is, potassium chloride was left in the patient areas, and it was freely without any protocol. So the question is asking, when this was discovered, what is the most appropriate response regarding the storage of potassium chloride? What should be done? Should option A, B, C, or D done? Okay, so perfect. Somebody said B, ensure the vials remain accessible. We have some A's, we have some B's. Again, as what we see with common issues with the exam, we are narrowing it down to two answers, right? And this is where the thought process is key. It is very important to understand questions are rarely repeated. Sometimes, yes, if they were pretest questions, they can be. But if they are not repeated, questions can be similar. That's why a thought process is very important. And that's where we try and come in and share our experience. So perfect. I see some A's, I see some B's. So let's look at the answer. This is great. The correct answer in this case is A. So all those who answered A, that's fantastic. ISMP Canada and hospital safety protocols require that KCl injection to be stored in a secured, restricted access area, such as an ADC, automated dispensing cabinet, to prevent fatal medication errors. Now, KCl injection has been implicated in many fatal errors. Simply labeling the vials or just training nurses does not eliminate the risk altogether. And with it being such a high alert medication, it is, or such a risky medication, if not having proper protocols, it can lead to someone's death. So that's why option A is the correct answer. And the best way that we teach in terms of thought process, the reason option A is the best answer, if we can go to the next chart that ISMP has, I tell all the candidates to look at the next chart. Pramit, if you can put the next one, the ISMP. So this ISMP chart, which is the hierarchy of effectiveness, is so key when it comes to the exam, because it helps you distinguish what kind of options are expected, what kind of options lead the best results in terms of error prevention. So as far as the exam is concerned, PEBC loves all high leverage options, which are forcing functions. Those are really great. Those ones usually lead to strong error prevention strategies. So removal of a product such as KCl from that floor is a forcing function. That means the hospital pharmacy staff would have to be involved, or it has to be in secured cabinet. So maybe a password has to be entered. So there is a lot more thought process that goes in before somebody can easily just access it and administer it, right? So that's why the high leverage functions are most effective. And always keep in mind system-based. So anything that is automated, that adds automation, is more effective than person-based. And person-based usually is education and rules and policies. Education and rules and policies, which are low leverage as opposed as per ISMP. What happens is the low leverage strategies are best used not as isolated policies. They should always be combined with other policies. So if as far as exams concerned, if you have a question that is putting an option of a low leverage, such as educating nurses, or putting in rules and policies so nurses don't access this ward, these are low leverage. So if they're listed by themselves, usually that is not the correct answer. Only when the low leverage strategies are combined with medium leverage strategies, such as some automation, some standardization, such as computerized physician order entry, electronic order sets, examples such as these, then the low leverage strategies do work well. But otherwise, by themselves, they're usually incorrect as the appropriate answers. Higher leverage strategies, such as forcing functions in the example we saw, usually those are really preferred by the exam. So make sure you pick those as opposed to the lower leverage ones. So I hope this gives you a little bit of sense of how we approach the thought processes in approaching these management questions. And before we move on to the course structure, any questions that you guys have about these questions, or any other general questions, or if you have questions about the attempt of the narcotic recon or the ISMP, feel free to ask us right now. Anyone? Okay. So thank you so much for participating, guys. That's great. Always see you guys. Always great to see you guys engage. I will hand it to Parmeet, but let me see if I can get. Is it reasonable to expect that each question will only test one key competency? No, Marie. So actually, more and more that we are seeing now, and in fact, what PEBC is starting to do is they're actually also integrating therapeutic and management questions by giving you one case, and they're actually mixing the two, therapeutic and management. So what this tells us is there's actually a mishmash of competencies being tested in one single case as well. So that would not be a reasonable expectation. I would say that you should be prepared as you move along to answer questions with therapeutics and management combined. Any other questions? Okay, so Parmeet, if I can hand it back to you, and thank you guys for
Thank you,
participating.
Arav. So yes, of course, if there's any questions, continue asking them. I'm just going to quickly talk about what our MCQ course schedule looks like. So our course starts February 10th. It is conducted twice a week on Tuesdays and Thursdays for approximately 12 weeks. So it is quite a lengthy course, and that is because there is a lot to offer. Timings will be 9:30 to 2:30 Eastern Standard Time, and then also 6:30 to 10:30 p.m. respectively on the Tuesdays and Thursdays. So you really have to pay attention to the schedule to understand what time your classes will be. Our course includes thousands of questions. Now, keep in mind, this is not quantity versus quality. All questions are meant to be in high quality. And as Farah mentioned before, just having access to question banks is never enough. So on top of the question banks, you get all our guidance, our books, and our classes to really learn every single topic in depth and understand it to the best of your ability. With our course, you also get a midpoint exam, which is launched after week number 9, which is focused purely on management and calculations, which no other course provides. That midterm exam really helps you focus and understand management and calculations in a lot of detail. And then once the exam is, or once the course is over, then you get access to 2 full timed mock exams at the end of the course, which gives you feedback based on competencies. So not only will you get a total score on your mock exam, on the final mock, but you will also get feedback based on each competency, each core competency. And that is, again, not done by many courses. You will also get access to a lot of self-study videos because, of course, there's many topics available in therapeutics as well as minor ailments, which is near impossible to cover in the entire course doing live lectures. So we have a lot of self-study videos that are going to be available as well, which you can study on your own time, but the classes are very important and kept for the big, large topics and a lot of in-class questions and cases. So not only do we teach you, but we also practice cases and questions in class, similarly how you saw Arav and Farah teach today. We again have a WhatsApp group available for our course, which gives you access to interact with faculty and peers. And then we're always there just in case students have questions. And we are working on a new learning platform. We already have one, but we're working on a new advanced learning platform, which is going to be launching soon in January, which is going to be the revamped website, giving you access to tons of goodies on top of this course. So registration is open for both OSCEs as well as MCQ. You can enroll by visiting SolRx today. For our OSCE course, the online price is $17.99. On-site is $19.99. And our multiple choice course special, the early bird price right now till the end of 2025 is $14.99. So all material for both courses are available immediately. And like I said, we will have a new learning platform launching in January, which will give you access to tons of other things as well. If you have any questions, we'll give you the opportunity to ask now. If you think of something overnight or in a couple of days, always feel free to send us an email or even call us, send us a WhatsApp message. We're all in the PBC general group, so you can always reach out to us easily if you have any particular questions. Like I said before, we're more than happy to have calls and discussions with you to make sure you are 100% ready before you enroll in our course. We want to make sure that all students are satisfied with anything that SolRx has to offer. So thank you, everyone. I know it was a long 2 hours, but I'm hoping the session was fruitful and it gave you a lot of information on what we have to offer. I know it was a Friday night, but thank you for those who stuck around till the end. And if you have any questions, please ask now. Is the midterm mock available for review after the exam? So Shireen, I'm assuming after the final mock, you're going to always have access to the mock exams for the season. So if you already did the midterm mock, you will still have access to it after the final mock exam as well.
Yeah, so I think so. If I understand correctly, yeah, exactly. So Shireen, once you've attempted the exam, you would have a chance to review it because you'll get the answers which were incorrect, or the questions which you attempted incorrectly, you'll get the correct answers.
Oh, yes, you will get answers to all quizzes and mock exams that you do in our course. Rebecca's question, do we need to refer to C2C as well? So like I said before, you don't need any other material outside of SolRx. We use all the references to develop our course material, so it's all in one area and concisely summarized for you to understand. So no need to purchase anything else. Can I sit in both OSCE and MCQ together if I prepare for November 2026? Absolutely. So if you find that you are someone that wants to take both exams together, it is definitely possible. We don't always recommend it depending on the individual that you are, but we've had many students in the past that took both exams together and they passed both of them at the same time. Of course, it does require a lot more effort and a lot more work, but if you're going to start studying now, which is almost a year before the exam, then by all means, it is very, very possible. You just have to make sure that you have a very strict study plan that you're following on a regular basis. And then no doubt you'll be able to pass both of them if you choose to write them together. Any other questions, anyone? Awesome. So if there's no other questions, I want to thank everyone once more and thank you to the faculty for making the time for tonight's session. And we really hope to see everyone in our future courses. Like I said, reach out anytime. Thank you, everyone, and have a good night and happy holidays.
Good night,
Thank you so much.
everybody.
Good night. Take care.
Bye.